So if we speak about macular hole surgery, we speak a lot about the anatomical results of macular hole closure rate, but actually that is not what our patient is interested in. Our patients want to have better visual acuity. And we know that the functional result depends strongly on the integrity of the outer retinal layers, especially the RPE, ellipsoid zone, and the ALM. So I won't be speaking about ILM flap techniques. We've heard a lot about it today. But I'd like to show you the results from our clinic with another wound healing approach we perform for all primary cases for surgery of high-stage macular holes. So as you see, we included in this retrospective analysis two groups. Some patients treated with still 20-gauge pars plana vitrectomy and some of them treated with 23-gauge pars plana vitrectomy. We performed the ILM peeling in all the cases and used gas and tamponade. We preferred C2F6, and patients have been asked to keep for prone position at least 2 days after surgery. We also applied autologous platelet concentrate intraoperatively. And in order to avoid longer surgery time, because we are convinced that shorter surgery times influence faster recovery of the function of the eye, we try to avoid doing combined surgery. So most of our eyes get the cataract surgery 4 to 8 weeks prior to performing the pars plana vitrectomy. As to the macular hole stage, these were all full-thickness macular holes, and the vast majority, as you can see, were large macular holes with diameter more than 500 microns. And the autologous platelet concentrate was injected immediately after performing the ILM peeling. It was about 0.4 till 0.5 milliliters, and we waited then for 8 minutes. And after the platelets have been washed out of the eye, and after normal gas tamponade was performed. So if we look first at the anatomical results, so in the total group we could achieve a good macular hole closure rate of about 90%. But if you see both groups separately, so we see a much higher closure rate in the 23 group pars plana vitrectomy. So that implies that shorter surgery time you need for 23-gauge vitrectomy and less trauma to the eye globe result certainly also in better results. If you look at the functional results, so we could achieve in both groups a good recovery of visual function, which was statistically significantly different compared to the baseline. But again, the 23-gauge vitrectomy group did much more better, and we could achieve a 0.31 logMAR visual recovery in this group. And this was also statistically significantly better than the postoperative visual acuity of the 20-gauge group eyes. All these results I have shown you regarding anatomical and functional success have been evaluated only 6 weeks after surgery. So that's why we're speaking about short-time results. We do not have a control group because we do this surgical approach for all patients in case of high-stage macular holes, but we wanted to compare our data with nowadays, I think, the largest report on the results of macular hole surgery. It was the United Kingdom National Database Study in Report 2, and there you could see that a similar visual recovery, 0.3 logMAR, could be achieved after 3 years of surgery, while in our study we could achieve similar results evaluating it after 6 weeks. And also almost more than 90% of the eyes in this report required, the phakic eyes required post-vitrectomy cataract surgery, which also bears some risks, as you know. So our wound healing concept consists in a triple procedure. We first perform the cataract surgery prior to doing the vitrectomy. Then we wait 4 to 8 weeks for the eye to recover. After it, we perform the small incision pars-plana vitrectomy with ILM peeling and gas tamponade. And last but not least, we use the autologous platelet concentrate in order to maybe achieve faster recovery of the retina in these cases. Thank you very much.
Is there any question from the panel or from the audience? If not, may I ask you a question? You are suggesting to do the cataract surgery before macular hole surgery. Why not together, combined? And second surgery is, what do you think the addition of autologous platelet adds to the surgery?
Thank you very much for mostly the second question. I didn't have enough time to tell it earlier. So we think that if you do combined surgery, that is still an option, but you have a longer surgery time. I think maybe 10 minutes longer takes it if you do that combined. And we are convinced that if the surgery time is shorter, even if you have then 2 steps and not only 1 step, that the recovery of the eye structures is going much more faster after the operation. And regarding the second question, there have been some studies published in the 90 years already, and they could show that autologous platelets have some factors which influence positively the migration and proliferation of the Müller cells and of the RPE cells. Whether this effect is that one we see in our patients, or it's mediated by some other processes, we cannot know it exactly, but we still see a very good and a quickly recovery of visual function. So I think the platelets do something